Okay, so now is everything okay?
Yes,
Thank you.
and thank you so much for joining us tonight. And today our audience is from Xinguang Medical Center in Taipei, Taiwan. They are all doctors and nurses consisting of experienced ophthalmologists who focus on cataract and refractive surgeries. And tonight you will share it about an additional step for achieving visual comfort and ELON's application, right?
Yes.
Yes, okay. Please feel free to start your presentation when you are ready.
Thank you. So, I said many.
This is just a rehearsal, right? Yes.
Yeah, we start?
Yes, we'll start.
Okay, good. So, thank you for the invitation. And I send many greetings to your country. And I mentioned myself and Professor Lasislav Pavel. You might know his name because he's very well-known name. He's he belongs to 100 the best surgeons in the world. And he's my medical advisor and my big teacher. And when we started refractive surgery in our institution of aviation, and we are responsible for all flying staff in Czech Republic, and he recommended me medical lenses because medical lenses, they are trying to develop as best as possible lenses, and we proved it. We already published 4 articles regarding lenses, special lenses of medical, and the latest experience, which we have at least 3 years, regards ELON lenses with extended depth focus. So let me show you just only very frankly some slides, and I would be happy for more discussion than just to seeing slides, because my presentation you might get from company, okay? So everyone knows, so we have normal eyes, we have presbyopic eyes, and we have some possibilities how to correct presbyopia. So there's some pros. With age, some trouble. So first we have low lights, then reading menus, then medication or labels, and then computer table, text, social media, okay? So we try to help people to restore their vision at least 20-30 years back. Okay, so presbyopia, it's very border some physiological status, and all of us we would like to solve if possible. And first we have to start with cataract patients and then with Novacek extraction. So what we would like, it is important to have some talking with each person, because we know hyperopic eyes or ametropic eyes or myopic eyes, they have some different physiological pathways and physiological reading in the visual cortex. So we have some possibilities how to solve these troubles. Either historically with monofocal lens, with micro or monovision, then we get bifocal lenses, which show us good far vision and reading, then trifocal lenses, and with trifocal lenses we watch, especially in the flying stuff, some side effects as the halos, starbursts, and the other ones. So the lower number of print we have, or the lower construction steps in the lens we have, the lower side effects we have, and precision with manufacturing with lenses. This is key point how to confine these side effects. The modern way, which seems to be very good for a major portion of population, is ATOF lenses. And every company promise whatever feature of the lens, but just on practice will show us how it's working. And we have in our practice, because I'm doing more than 1,000 cataracts every year, so at least 1/3 of patients are using ELON lenses and they are better. So presbyopia correction. The upper part is the trifocal lenses, and the lower part show us the off lenses, the lenses that have expanded depth of focus. So, each patient is a different person, and we have to ask them what they would prefer. If sports, hobby, or computer work, or if they need to see some details. And depends on their ask, depends on their demands, we might to choose which lens, depends on our experience we would to use. So look at this. This is from 2019. How many patients were implanted with the lenses? So even in 2019, 20% of patients were suitable to get lens with extended focus. Medical company that developed lens with very nice precision. You see in a 2 mm zone they use 4 steps without any sharp design. To confine any side effects, and the lens brings us elongated focus. Look at this monofocal lens and diffractive bifocal lens and ELON lens. Everything depends pretty much in pupil size, because as we know, pupil size plays a major role how each lens would work. This is our lens, so you see very big range of color, even the extreme color, and this lens is designed pretty precisely, and this is a hydrophobic acrylic material. We use medical lenses since 2016, and we never seen any opacification of the lenses, never seen listening. Of course, posterior capsule act low vibration in each lens in a different percentage, depends on shape of the lens. But opacification we never seen it, and we are really happy for these things, especially in our clients. There was established some group of 11 surgeons in 2021 to get some experience, and as I said, we already issued three articles with our experience. So you see, it's going around the world. We have from Czech Republic 3 major surgeons, myself, Dr. Potter, and Professor Lasislav. But as far as I know from last Congress, about 1/4 of surgeons from whole Czech Republic have some experience with medical lenses, especially with ELON, and I never heard anybody has bad experience. So this is my personal opinion. It's good choice. So this study is ongoing up to now, and we have ready the 5th article regarding ELON lenses, and all patients had to underwent very special examination, especially contrast sensitivity method test, and overlightening and the work in the shadow, So we do a specific test for our flying staff, and we think end of this year or beginning of next year we would publish these results. And until, as far as I know, almost all patients are very successful in these tests. So these are results. 63 patients, 126 eyes. You see uncorrected and corrected visual acuity is pretty good. And we manage around all surgeons to reach very nice results. Look at this, 85% of patients we manage to have in the range of plus minus half an diopter. Okay, so I think it's okay. The performance of it's really valuable. Look at this. There's depends of our experience with monocular vision 2020 without corrections only half an of patients, but binocularly it's 80%. 80% 2020 vision. There is some our knowledge. If you implant just monocular, for example, if some patient has some injury, I don't think so. It's so perfect choice. But if you implant presbyopia patients or cataract patients with binocular implantation, so you reach immediate level 80% of very happy people. And 100 people uncorrected 20-25 vision, I think it's pretty good because it's for all activities, even for driving car, night vision activities and everything. So now you can see the focus curve, which is pretty good. And company promised us reading, let's say, Geiger number 4 or 5. But most patients could read letters Geiger number 3 or 2. And that's our experience. And later on, I'll show you some way of blending vision. So they are very happy without any gap and lack in intermediate vision or even in reading vision. So I can say honestly, most about 80% of my patients, they don't use glasses anymore for computer, for cell phone, even for menus in the restaurants. There's another focus curve, and this is curve regarding contrast sensitivity. Contrast sensitivity is one of the major characteristics how they would see during driving car or under low light conditions. So all patients underwent some questionnaire form. So overall satisfaction is almost 90%, with almost no side effects. We asked them for distance vision, intermediate vision, and near vision. Near vision, nobody promised them better than Geiger number 4. So it's up to everyone could look how they calculate biometry if on first plus or on first minus, depends of needs of patients. We proved they have no severe difficulties with this photopsia. Okay, there are the latest articles, so there is very nice answer. About 75% of patients would choose the same IOL for implantation again. So I don't know of your experience, but in my office, in my practice, my experience, if some patients, about half of them would choose some same lens. So I would say this lens is not bad. if it's 3/4 of patients, so this lens will be pretty good because we have to count even very difficult cases, not only patients with platelet extraction. Good visual function for everyday tasks, reading, recognizing faces, seeing prices, and walking on surfaces, handicrafts, reading subtitles, hobbies. So for hobby patients, for example, playing golf or for retired person, I would say this lens is fabulous. Dr. ELON from South Africa, he has also some experience. So look at this. 86% did not experience with the throbbing phenomena. So it's same, it corresponds with our results in our study. So I think nobody would say it's not working. And this is concept of blend zone in micromonovision. So we use this schema also for dominant eye. We calculate as near as possible for plano, dominant eye for 0, and non-dominant eye slightly myopic. So most of the patients are very happy, and it's same like in the study. So there is some experience. I think it's almost same like our eyes. There are some patients, 18 patients, and we implanted about 230 patients yearly. So I agree with the results. And I would say come over and to see or try to do it, depends on this schema, and you will be happy, your patient will be happy. I don't know exactly specific of Asian eyes, but the lens is very easily implantable, and the predictability of the refractive results are pretty good. In our study, which was published years ago, so we had even better target refraction. So in this study, the focus curve corresponds like before in the previous one, and contrast sensitivity also. So we can extend contrast sensitivity curve, and it corresponds like in physiological stuff. And now we have a study with native eyes, with clear lenses, patients 50 plus. The lens is monofocal, and patients with lenses, ELON lenses, with depth of focus. And I have to tell you before then article will be published. So I agree. Those patients are very happy, and even the curves are really good. There are some characteristics of the study. It's not so important, you might see. And in conclusion, the preloaded lens, ELON, are very safe and efficient, and the predictability is pretty good of refractive results, and patients are very happy, not only with intermediate vision, even with near vision, they are very satisfied, and it's in many cases, let's say more than 60%, it's better than we would expect. So satisfaction of our patients with very minor difficulties, it's key point to having good practice and good name. Thank you for this presentation. So can we everyone? Sorry, I don't see you. I don't hear you.
Thank you, Dr. Novacek. Can you hear me?
Yes, I hear you. Thank you very much.
And
Okay, now I can see you.
you will have another one add-on application to share with us, right?
Yes, yes, yes. I'm trying to. Hold on 1 second. Yes, yes, yes. Okay. It's okay now. Now you can
Yes,
you can
yes,
see.
yes. Please feel free
It's
to
okay.
start. Yes.
Let me open personal discussion. Do you have any one of you any question regarding ELON lenses?
Dr. Novacek, we will collect all the questions after the event and we send you by email.
I hope we have some time because the presentation is pretty long, so I would like to confine for some only important facts, all right? Do you hear me?
Yes, yes.
Okay, okay. So, ELON lenses, there's some trick how to help patients, how to solve some complications, how to improve their vision after implantation of one of the lens, or how to solve our surgical error. So, first of all, we have to just think how many cataracts worldwide is done a year. So we have big range of patients which are not quite satisfied after operation because, as far as we know, cataract surgery with very large and hard cataract is the past in many countries, if in developed countries. Of course, we have many places in the world patients are happy to seeing anything. For example, 30% of the vision instead nothing. I was twice in India, so there is completely different spectrum of patients. So they are doing mainly echo operation, but they have also hospital with very precise settings and they are focused for some precision of the patients. So I respect them and they do pretty nice and good surgery, and we see on the world, so they are the most skilled surgeon. But anyway, in our population, in our developed country, we have big pool of patients who would like to have something better than after a primary operation. So, for example, your neighbor or anyone could see much better because has implanted new lens, but at all for trifocal lens, or there's some remaining of astigmatism, and or sometimes it would happen some mix between dominant and non-dominant eye, and we might just tell. For example, I have my own experience. I made operation cataract surgery in very high known person in Czech Republic, and there was different just order diopter. And the guy was very unhappy. And I was about decision if we could do some laser, but his cornea was very thin. So I decided to put additional lens, and the patient now is one of my most happy patients because he can see clearly 2020 because I manage this 1/4 diopter increase the power of the lens system. So we have some options: spectacle, contact lenses, laser, refractive surgery, IOL exchange. How many of you are doing routine-based IOL exchange? I don't know. I did it many times in university clinic, because there's clinic, the last position where patients complaining are coming. And when we have some possibility to put in lens, so we are very happy and we tried it and we use it. I think it's in our regular protocol, and if it's suitable, we would see later on. So patients, most of them, they're very happy. So, what means add-on lens? Add-on lens is lens which we implant to sulcus and we add it to primary IOL. So, well, we had some question. If the primary lens is hydrophilic or hydrophobic, if they might be some blistering or not. So there are many questions. We make experience if the primary lens, anyway, we started with compatible material whatever lens. So we had a big group of patients with medical lenses, with hydrophilic lenses, and we added this add-on lens, and there were no complications at all. And we implanted many lenses, let's say 150. Then we start with listing free lenses, and we found there's also no complications, and I'll show you what is the trick of this particular add-on lens. So this is some timeline what we had, and the first implantation of the IQ add-on lens was 2010. We implanted first lens 2016, and we had shown this implantation in live surgery in Czech Ophthalmic Society. And since these days, those patients, they have no complications at all, even regarding endothelial cell slide. In the past, we might use piggyback or the other possibilities, and everyone knows it might have some complications like listening, listening or pacification, and there is no easy solution, only explantation and implantation another kind of lens. The company had some challenges, oil materials, oil diesel. So this particular lens has 4 very flexible haptics, and every surgeon knows irregularity of the eyes. There's something what we would not do. We don't like this. But this lens, most of the cases can solve with the haptics, because the haptics are independent and the position of the lens is pretty good. Let me show you some simulation, and depends on our experience, one side of the lens can solve most of the eyes. I'm not talking about microphthalmos or some scarification or injury, but in normal eye, it's working pretty nice. There is some trick of implementation, so you have to practice a bit. and manipulation with the lens is not so easy from beginners because it's very tiny. And I call personally this lens idle because the legs, the haptics are really tiny and very gentle. So we have to work with this lens very carefully. So there is another simulation and there is answer for especially toric lenses. What would happen with toric lens with the rotation during shrinkage of the capsular bag? So even in these cases, the lens is very stable and we can prevent rotation, which nobody likes. And there is another case which nobody likes, especially the left side with the tri-pieces lens, the one every surgeon knows, especially after rupture of the posterior capsular bag. So it might happen, let me show you again. So this is something what we doesn't like, what we really hate, especially second day, if it would happen. And especially in refractive surgery, or if we try to solve some refractive error, so we try to avoid this situation. So design, because of my opinion, is pretty good and really nice. Another trick is the distance between that on lens and the original lens. So the space is protection of opacification, what we seen in the slide before, and the precision of the space is really good. So the haptic force should be enough gently and enough powerful to stabilize the lens in good position to achieve good refractive result and rotation stability in the case if we would implant some toric version. There is another simulation, and we proved with intersegment OCT, so there is really nice space, regular. And let me show you another important point. We have also UBM, so degree of angle is really crucial. After implantation, we have to check if there's enough wide angle. So the minimum anterior chamber depth is 2.8. So especially in Asian eyes, you have to be very careful. If there's less than 2.8, you are in risk of losing endothelial cells. But most eyes, after implantation primary lens, has enough, the deepness of the anterior chamber is enough, because after extraction of natural lens and implantation, very tiny lens, in most cases we can reach good deepness. So another task for anyone who wants to implant any lenses, it's calculation. So we have some calculators and you have to some experience. But the procedure is reversible. So anyone who is keen to use these lenses has a chance for reversion of this procedure and to fix it up. Of course, there's some learning curve. So let me show you. Okay. First we start, same thing with the presentation, with refractive errors, with miscalculation, misalignment, with wrong implantation. We get experience with implantation with the lens, and we proved the lens is very stable and very predictable results. Then we get some encourage to correct astigmatism. So you have some possibilities how to correct with incision or laser treatment or with other lenses. And we proved this position where the lens is very stable, and we encourage ourselves, and depends on our experience, mostly we correct the astigmatism to, let's say, 3/4 or a bit, or 4 points from 5 to total astigmatism, and most time we have very satisfied patients. Of course, we have to know the astigmatism before primary operation. So we have to take into account primary astigmatism, astigmatism after implantation of the lens, and then something between in these two astigmatism and axis, depends on calculator, you do biometry of the lens. Most time we manage to bring beneficial vision and final refraction for patient in for satisfaction. We met some patients with trifocal upgrade. It was on purpose because we had started with the bird lens, the Ateliza lens, and the primary implantation monofocal lens with other lens with trifocal pattern. We observed there is no difference between primary implantation of trifocal lens and combination with monofocal at-home lens. In our study, we wait for implantation of at-home lens 1 month. It was designed like this, but we know if there is some risk of patient satisfaction, or if we have some other question, if it will be okay or not. So we might implant multiple lens on lens in one operation because of reversibility of explantation of at-home lens. So if there is any side effects which patient couldn't stand, so we might reverse this side effects belongs to trifocal optic design shape, and some special patients, especially I think they are a bit psychiatric, so we might to go further with this option. Sometimes they are challenging cases. So after injury, after removal of silicone oil, after retina operation, if macula is on, and the potential of the vision might be pretty good. So we might do secondary implantation and correction of refraction with the F1 lens. So now, what kind of lenses we have available? So monofocal, toric monofocal, trifocal, and even trifocal toric. Some evidence of markers. Safety, long-term IOP. We never seen long-term elevated IOP. Of course, you have to use during implantation viscoelastic because implanted lens underwater, it's very risky for endothelium, and we are not too risky. So hyaluronide or very quality visco material you have to use during implantation, and there is no possibility to remove all the visco even though you irrigation aspiration used for a long time. So elevation of IOP, let's say for up to 1 week, it's normal, but we didn't observe that longer than 10 days. Because each eye is a bit different, but most patients, the second day after implantation has very slightly elevated IOP, but after 1 week there is normalization of pressure. Iris function and posterior chamber integrity. Any complications? I agree. We had no. In first patients, I would say about 5 patients, we have to learn how to handle with this lens, because as I told you already, the haptics are very tiny, and the manipulation in the anterior chamber, you have to have a bit practice. Regarding efficacy and predictability and long-term stability of optical correction, we have very good correction, and optical effect of 2 IOLs in the eye, there is no difference between one lens. Retinal image quality is pretty good, and we did measurement quality of optic system of the eye by special tool HD analyzer. So there are some functions with pulse spread. So the more point is spread by double cast of the optic system, so the less contrast sensitivity we can get. But regarding eyes with con lenses, there is no significant difference if you have 1 or 2 lenses. So the lens, depends on my experience, fits perfect. There's another study, and regarding IOP. So if we watch IOP during long time, 3 months, 6, 12 months, there is no difference. Just only the viscoelastic increase IOP temporary. Okay. This shape, convex concave, is designed, I think, reasonably, and the space, it's enough wide to protect any classification, and the position is very stable. If we do measurement 1 month after implantation or after 1 year, it is saying the difference between space almost nothing. Sometimes due to shrinkage or vibration of the capsular bag, but that is most time in the first year, and then it's same. Okay. I think I already told everything what I would like to tell you, and I would open some discussion to compare your experience and our experience, and I'm ready to answer your questions. Are you there?
Yes, we're right. And we
Hello.
will collect all the questions after the event.
Can you hear me?
Yes, yes, we can hear you. Hello, Dr. Novacek.
Can you hear me or?
Yes, I can hear you. Can you hear me?
Yes, yes. Now I hear you. Thank you.
Yeah, we will collect all the questions after the event and send you by email.
Okay.
Yes, and please continue your presentation.
Hello.
Novacek,
Hello.
Hello, Dr. Lasislav. This is Dr. Buchanan from Shinkong Wu-Fosai Memorial Hospital. May I ask one question?
Yes, please.
This ELON is a major religion, and I would like to ask if the refractive power is appropriate. Is it possible to use it as a single lens, as a imagine backup if posterior capsule is ruptured instead of an ELON?
Yes. Okay. Thank you, doctor, for this question. It's a pretty good question. Any surgeon has complications, and most common complication is with a posterior capsule rupture. And there are three ways. Either you have either you have complications with the vitreous body, and you have to do some anterior vitrectomy. So, if you manage to implant the lens, the original back, and after sometimes, let's say, a difference of me 6 weeks, you might implant a lens without any trouble regarding biometry. If you have to implant 5 pieces lens in the sulcus, so there is question. It's, I think, in the on order about the depth of anterior chamber and stability of the lens. And everyone we know something which we call dead back. So depends of each case. We have to decide if we would use add-on lens or not. So as I mentioned, we have HD analyzer. So if there is no concentration of the primary lens, if there is enough space for add-on lens, so we don't hesitate to use add-on lens, because during the operations, depends of your experience, sometimes you have to lower the power for lens to implant to sulcus, sometimes you don't have another lens, and then there is option how to solve the situation with that lens. That's my own experience. Of course, we have the patient like this. Especially, I had one light surgery, and the lady was pretty nervous, and something happened in the theater. And during this operation, we have complication like rupture of posterior capsule. So, thank you for the question. If I didn't answer you correctly, so ask me again.
Okay, I got it. Thank you very much.
Thank you, Dr. Novacek. Thank Thank you for your presentation.
Thank you. Thank you too. Thank you
Thank
too.
you. We truly appreciate. Thank you for your time and support.
I hope to see you in the meetings. Thank you very much. You are very nice.